So next patient is a 62-year-old male present with right inguinal hernia. The hernia has been present for 2 years and is asymptomatic. He is otherwise fit and well. What is your management plan? The plan is for elective mesh repair using a laparoscopic or an open approach. There is 2% risk of developing complications. In addition, there is no increased incidence of chronic groin pain. So non-surgical management such as truss is used for symptomatic patients not fit for surgery. Do consider the feasibility of hernia repair under local anesthesia. What is a hernia? A hernia is an abnormal protrusion of a viscus or part of viscus through its normal covering or into the abnormal site. What are the borders of inguinal canal? So anterior wall is formed by the inguinal ligament and lateral third with the internal oblique. Posterior wall formed with the transversalis fascia and conjoint tendon. Inferior wall by the inguinal ligament and medial third of lacunar ligament. Superior by conjoint tendon. What are the types of inguinal hernia? This is very important. There are two types of inguinal hernia, direct and indirect. So direct hernia, slow increase in size with low risk of incarceration or strangulation and 0.5% chances of strangulation per year. And indirect hernia, because it comes from the deep ring, so there is a high risk of acute events, 2 to 5% per year. It can like having strangulation or incarceration. Male to female ratio is 12:1. The common presentation is a painless or painful groin lump, and then the elderly and irreducible groin lump. Risk factors include advancing age, obesity, COPD, chronic constipation, benign prostatic hyperplasia, and connective tissue disorders. What are the principles of inguinal hernia repair and what approaches are available? So approaches are laparoscopic and open. So definition of the anatomy. So define the anatomy, identification of the sac, assessment of the viability of its contents, and acute presentation, and repair using a synthetic material as a day case procedure. So modified Lakenstein is Lakenstein technique, widely used open technique and shown to have minimal long-term recurrence less than 1% in 10 years. Laparoscopic repair recommended for bilateral and recurrent hernias may be offered as an elective approach to unilateral hernia. This is particularly relevant to women who have a higher incidence of an occult femoral hernia. The two widely practiced approaches are total extraperitoneal repair TEP and transabdominal preperitoneal repair TAP. What's the most favored surgical approach and why? So laparoscopic approach is more widely used than the open repair. The laparoscopic approach is preferred as it causes three advantages: less postoperative pain, lowers the incidence of chronic groin pain, therefore facilitating the early return to the work. But there is a downside. There is a slight higher recurrence rate reported as compared to the open one. Describe an ideal mesh. So it should be lightweight, less than 80 gram per meter square. Large pore should be more than 1 millimeter so that it don't make a solid fibrotic plate resulting in a shrinkage of the mesh. Must be able to cope with the transient increase in abdominal pressure more than 200 centimeter of mercury. And laparoscopic meshes should handle well and not cause bowel adhesions. How would you treat a patient with a recurrent inguinal hernia after a previous open repair? In addition to the laparoscopic approach, a transinguinal open and preperitoneal mesh repair like Reeves or Stopar procedure can be considered in selected cases. However, it has a higher chances of recurrence between 0.5% to 25% in 10 years' time. You repair the inguinal hernia, but patient presents 3 months later with chronic groin pain. This is called inguinodynia. Inguinodynia. How will you manage him? So inguinodynia can happen into the inguinal hernias up to 40% of the patients. It can be due to Neuropathic or non-neuropathic. So neuropathic usually happen to the local injury, and non-neuropathic due to the mesh-related fibrosis of ilioinguinal nerve, iliohypogastric nerve, and genital branch of genitofemoral nerve. Risk factors include the young age, preoperative pain, and pain at the other sites. Management: lifestyle modification, NSAIDs, tricyclic antidepressants, surgical or chemical neurosectomy. So, NSAID surgical chemical neurosectomy in selected cases after successful recovery, although there is no consensus in the treatment approach. A prophylactic neurectomy during hernia repair significantly reduces the incidence of gynodynia. Referral to the chronic pain team should be considered if this does not settle with the Myers. Thank you.